propose to do is propose the future activity planning of this group of heart in diabetes, and I will propose certain research projects and certain other academic projects to be done in the coming year. So my time is 8 minutes only. So actually the research projects which I will be proposing, we already have seen that cardiovascular research in diabetes is critical because Indians are uniquely disadvantaged and have more CVD risk. Pragmatic multi-centric research is needed to frame our own guidelines and to know what is going on in India. So project 1 is building on the topic of Dr. Anil Virmani, use of CVD risk calculators in India, because we do not know what is the extent of use of CVD risk calculators in India and what are the factors which are hampering the use of these CVD risk calculators. I must say there are two types of CVD risk calculators. One are simple, where they have very less variables, and one are very complex, where they use lot of variables like duration of diabetes, smoking, ethnicity. So there are a lot of variables to be put in. Now the flip side of both of these is simple calculators may underestimate or overestimate the risk, and the complex calculators are difficult to use. So basically we can do a study to know what the physicians, diabetologists, endocrinologists are using in day-to-day practice as far as CVD risk calculation is concerned, basically, and go ahead with the study. It can be a multi-centric cross-sectional study where physicians, internists, diabetologists, all can be involved, and it can be a structured questionnaire, and it can represent across practice settings, basically. So we can also know the barriers to the calculator use with the use of this research project and the expected impact, whether we can improve the risk of these calculators or not. Second thing which I would propose in this coming year is LDL and triglycerides are the key modifiable CV risk factors, and guidelines recommend aggressive LDL lowering, while triglyceride lowering strategies vary widely and are having great controversies. Real world lipid targets vary. Escalation practices are inconsistent. So we can have a study on this also. We can collect, every center can collect data of 50 diabetic patients, and their practice trends and their practice patterns can be noted, and their statin initiation, choice, intensification, combination, everything can be noted. We can also note the triglyceride management strategies also, because they are very, very controversially sort of administered, and we can know what is going on in India, and we can frame our own recommendations and publish evidence about the same. The third is, which is very, very sort of looks important to me, is urine ACR serial measurement and its relation to cardiovascular risk. You know, the urine ACR is the first marker of vascular or endothelial dysfunction. That is what I can say, and it is basically not the kidneys only, it is the entire system which is affected. And if we can see the urine ACR, and it can be a longitudinal study, and we can see the events, cardiac CVD events occurring in these patients who are having a rising urine ACR levels, and those who are having urine ACR positive. We can study the urine cardiovascular outcomes in these patients, and we can know the risk stratification value of urine ACR, and in particular a rising urine ACR, and the impact on addressing the therapies related to urine ACR, and a broad CVD protection in patients who have positive urine ACR, that also can be studied. Project 4, building on the topic of Dr. Brij Mohan, is diastolic dysfunction and MSLD, and we can note the correlation of MSLD with diastolic dysfunction, because both of them have a shared inflammatory and fibrotic pathway. So we can have assess the patient. We can do the study design, again will be multi-centric design, and we can study the diastolic dysfunction using all of these parameters which are mentioned here, and liver disease assessment using the different calculators as well as FibroScan and USG, and we can correlate, and we can form a strategy to address these patients, to treat these patients, where we can have a more aggressive approach so that the diastolic dysfunction can be avoided. Another project we can do in this year is renal markers of cardiovascular risk and guidelines management strategies being followed in India. We can see the microproteinuria and other renal parameters, and we can see how our physicians are managing these cases, whether they are using Fineron, whether they are using SGLT2 inhibitors, whether they are using all of these recommended therapies for preventing the CVD risk. The RAS inhibitors, the SGLT2 inhibitors, GLP-1, blood pressure, lipid management, all. So we can go ahead with this study also, where these patients who have urinary markers like urine ACR on the positive side, whether they are getting the optimal treatment or not, and we can have our own guidelines and position statements on these patients and how to go about. And this can be done across specialties like the internist, diabetologist, endocrinologist, and we can see the variations in therapeutic approach. So another project we can go is young onset diabetes and CVD. Even a lower ASCVD risk in younger patients will translate into a increased lifetime risk of CVD because they are exposed to this risk for a longer time. So here we have to be more aggressive basically, and we can go ahead with a multi-centric cohort study, and we can do a baseline CV risk profiling, and we can follow up for CV outcomes, and we can compare this with the older onset diabetic patients basically. So we can assess their risk factors, and we can assess their cardiovascular outcomes basically, and the clinical implications of early preventive strategies can be considered, and we can frame newer guidelines regarding the CVD risk protection in younger patients with diabetes. Now, now we can also have our own guidelines also related to heart patients in diabetes, and these guidelines can encompass patients with diabetes, with cardiomyopathies, with heart failure, with ejection fractions, with the urine ACR positive. We can have guidelines regarding patients with diabetes, with hyperlipidemia, with diabetes with CKD, diabetes with heart failure, diabetes with atrial fibrillation. So all of these are different areas basically which are yet unexplored, where we can frame our own guidelines and we can issue our own expert statements to guide our fraternity regarding how to risk stratify these patients and how to go about these patients. And because our guidelines will vary compared to the Western guidelines, because we have different risk factors, we have different presentations of CVD in patients with diabetes. We have a lesser assessment of sarcopenia. Our obesity standards are different. That risk scores they use, like the Shadwell score they use, is not applicable to Indians because of various factors. So we have our own unique population, and we should go about framing our own guidelines in different category of heart diseases in diabetic population. So with this, I would like to encourage all of you to think on these lines, and if you are willing, you can take up one of these projects, and this can be done through Diabetes India. Thank you very much. I will